Question 1. Radiation biology and radiation protection. Ionizing radiation can cause both deterministic and stochastic effects on human tissue. Which of the following statements correctly describes the difference between these two effects? A. Deterministic effects occur at any dose, while stochastic effects have a threshold dose. B. Deterministic effects have a threshold dose and their severity increases with dose, while stochastic effects do not have a threshold and their probability increases with dose. C. Stochastic effects always lead to immediate tissue damage, whereas deterministic effects manifest years after exposure. D. Both deterministic and stochastic effects follow dose-response relationship with no threshold. Answer. B. Deterministic effects have a threshold dose and their severity increases with dose, while stochastic effects do not have a threshold and their probability increases with dose. Explanation. Deterministic effects e.g. skin burns, cataracts, radiation pneumonitis have a threshold dose below which no effect occurs. Their severity increases as dose increases. Stochastic effects e.g. carcinogenesis, genetic mutations have threshold and occur randomly with increasing probability at higher doses, but severity is independent of dose. Answer and ICAP guidelines classify deterministic effects under non-stochastic effects, while stochastic effects are governed by probabilistic risk models. Incorrect answers. A is incorrect because deterministic effects have a threshold while stochastic effects do not. C is incorrect because stochastic effects e.g. cancer manifest over time, while deterministic effects can be immediate or delayed. D is incorrect because deterministic have a threshold while stochastic effects follow a linear no threshold LNT model. Question 2. Scenario-based clinical applications in radiation oncology. Dr. Emily Carter is a radiation oncologist treating a 55-year-old male patient with stage 1 non-small cell lung cancer SLCR. The patient has a history of COPT and has previously received 60 GI of radiation to the thoracic region 2 years ago for a different malignancy. Dr. Carter is considering reirradiation but is concerned about toxicity. Based on current clinical guidelines, what is the best course of action? A. Proceed with standard 60 GI radiation therapy without adjustments, as prior radiation does not impact current treatment. B. Reassess lung dose constraints, use highly conformal techniques such as IMiT or proton therapy, and consider dose fractionation adjustments. C. Completely rule out reirradiation, as any additional dose will lead to fatal pneumonitis. D. Administer palliative radiation at a lower dose without advanced imaging or adaptive techniques. Answer. B. Reassess lung dose constraints, use highly conformal techniques such as IMiT or proton therapy, and consider dose fractionation adjustments. Explanation. Reirradiation of the lung is high risk due to the potential for severe toxicity, especially radiation pneumonitis. However, it can be done with careful dose assessment and modern techniques. IMiT or proton therapy can spare healthy lung tissue, and dose constraints must be considered, e.g. cumulative mean lung dose should not exceed 2.025 GI to reduce pneumonitis risk. Incorrect answers. A is incorrect because prior radiation significantly impacts tolerance limits for reirradiation. C is incorrect because reirradiation is possible with advanced planning and adaptive therapy strategies. D is incorrect because palliative radiation may be suboptimal if the goal is curative or long-term control, and newer techniques such as Ford's CT should be utilized for precision. Question 3. Radiation therapy equipment and quality assurance. In a quality assurance CAR test of a linear accelerator LINAC, a physicist notices that the output of the beam has increased by 5% compared to baseline measurements. What is the most appropriate response based on CAR protocols? A. Continue treating patients as a 5% deviation is within normal variation. B. Investigate and recalibrate the machine as deviations above 3% require corrective action according to TG51 and ERF 398 protocols. C. Reduce the monitor unit's mu per fraction by 5% to compensate for the increased output. D. Ignore the issue and repeat the CAR test in a week to check deviation persists. Answer. B. Investigate and recalibrate the machine as deviations above 3% require corrective action according to TG51 and ERS 398 protocols. Explanation. TG51 OPAM and TRS 398 IA protocols state that a 3% variation in machine output requires immediate investigation and correction. 5% increase in beam output could lead to significant delivery errors affecting patient safety and treatment accuracy. Incorrect answers. A is incorrect because continuing treatment without corrective action violates CAR guidelines. C is incorrect because MU adjustments should never be made manually to compensate for machine calibration errors. D is incorrect because delaying corrective action could lead to excessive dose delivery and potential patient harm. Question 4. The role of LET in radiation therapy. A radiation oncologist is considering using proton therapy instead of conventional X-rays for a pediatric brain tumor. One of the primary considerations is the linear energy transfer, LET, and its effects on biological tissue. Which of the following statements about LET is correct? A. Protons have a higher LET than X-rays, leading to more dense ionization and greater biological damage. B. LET has no impact on the effectiveness of radiation therapy. C. Low LET radiation. E. G. Photons is more effective at causing double-strand DNA breaks than high LET radiation. E. G. Alpha particles. D. The relative biological effectiveness. Or B. is independent of LET. Answer. 8 protons have a higher LET than X-rays, leading to more dense ionization and greater biological damage. Explanation. LET measures the energy deposited per unit length of tissue, and protons have a higher LET than X-rays, leading to greater biological damage. Option B is incorrect because LET influences how effectively radiation kills cells. Option C is incorrect because higher LET radiation, e.g. protons, alpha particles, causes more lethal double-strand DNA breaks. Option D is incorrect because OB is directly related to LET. Higher LET generally increases OB. Question 5. Dose volume histogram DEH interpretation in treatment planning. A medical physicist is analyzing a dose volume histogram EH for a patient receiving intensity modulated radiation therapy IMA for prostate cancer. The goal is to ensure tumor coverage while minimizing dose to organs at risk cause, such as the rectum and bladder. Which of the following is the best way to interpret a cumulative DH? A. It shows the percentage of a structure receiving at least a given dose. B. It provides direct information on radiation-induced toxicity. C. It is not useful for treatment planning in modern radiotherapy. D. A steep slope in the DVH for normal tissue indicates poor dose sparing. Answer. A. Shows the percentage of a structure receiving at least a given dose. Explanation. A cumulative DH plots the percentage of a structure receiving a given dose or higher, helping assess both tumor coverage and normal tissue sparing. Option B is incorrect because it does not directly predict toxicity. It must be correlated with dose constraints and clinical data. Option C is incorrect because DHS are essential for modern treatment planning. Option D is incorrect because steep slope in the DVH for normal tissue suggests good dose sparing, rapid dose fall-off. Question 6, scenario-based, radiation protection and shielding design. Dr. Patel is a medical physicist responsible for designing a new radiation oncology treatment room. The facility is installing a high-energy linear accelerator LINAC that delivers 15 MV photon beams. To ensure compliance with ARPANSA and ICAP guidelines, Dr. Patel must determine the appropriate primary and secondary barriers for protecting staff and the public from exposure. Which of the following factors should Dr. Patel prioritize when calculating barrier thickness and ensuring regulatory compliance? A. The patient's body acts as an effective radiation shield, so only primary barrier shielding needs to be considered. B. The occupancy factor, workload, use factor, and shielding material properties all influence the required barrier thickness. C. The inverse, square law, does not apply to radiation shielding calculations because photon beams are highly directional. D. Secondary barriers are only needed in areas directly in the beam path, as scattered and leaked radiation are negligible in modern LINACs. Answer. B. The occupancy factor, workload, use factor, and shielding material properties all influence the required barrier thickness. Explanation. Barrier design depends on several key factors. Workload, W, total radiation output of the LINAC per week, use factor, fraction of time a particular barrier is directly exposed. Occupancy factor, T, how frequently people are present in an adjacent area. Shielding material, the material's density and atomic number influence attenuation, E. G. Lead versus concrete. Option A is incorrect because patients do not provide effective shielding. Some dose passes through the body or scatters. Option C is incorrect because the inverse square law applies to radiation intensity and is fundamental to shielding calculations. Option D is incorrect because secondary barriers are required due to leakage radiation from the linac and scattered radiation from the patient and walls. This is key topic in radiation safety and facility design, ensuring patient and staff protection in clinical environments. Question 7. Radiation exposure limits for occupational workers. A radiation safety officer (RO) at a hospital is training new radiologic technologists on occupational dose limits as set by the National Council on Radiation Protection and Measurements (SRP). What is the annual occupational dose limit for whole body exposure for radiation workers in the U.S.? A. 50 msv 5 rem, B. 100 msv 10 rem, C. 10 msv 1 rem, D. 5 msv 0.5 rem. Answer: A. 50 msv 5 rem. Explanation: the SRP recommended annual occupational dose limit for radiation workers is 50 msv 5 rem. Option B is incorrect because 100 msv is higher than the annual limit. Option C is incorrect because 10 msv applies to the public dose limit, not workers. Option D is incorrect because 5 msv is the limit for the general public over a 5-year period, not for occupational workers. Question 8. Brachytherapy source selection and dose distribution. A radiation oncologist is planning a high-dose rate HDR brachytherapy procedure for a cervical cancer patient using an iridium-192 O192 source. The physician is comparing it with cesium-137, cesium-137, and iodine-125, I-125. Which of the following is the reason for choosing O192 for HDR brachytherapy? A. O192 has a shorter half-life than CS137, allowing for more frequent source replacement and dose customization. B. CS137 has a higher specific activity, making it the most appropriate for HDR brachytherapy. C. I-125 is the best choice for treating deep-seated tumors due to its high penetration energy. D. O192 produces alpha particles, making it highly effective for destroying tumor cells at close range. Answer: AO192 has a shorter half-life than CS137, allowing for more frequent source replacement and dose customization. Explanation: O192 is preferred for HDR brachytherapy due to short half-life, 74 days, allows for frequent source replacement and precise dose control, high specific activity enabling small source size for better dose conformity. Option B is incorrect because CS137 has a lower specific activity than O192 and is used mainly for LDR brachytherapy. Option C is incorrect because I-125 is used in low-energy permanent implants like prostate brachytherapy and HDR treatments. Option D is incorrect because O192 emits gamma rays, not alpha particles. Question 9. Radiobiological effects of radiation on different tissue types. Radiation-induced effects vary among different tissue types due to differences in their radiosensitivity. A radiation oncologist needs to determine the most radiosensitive tissue for an upcoming treatment plan. Which of the following tissues is the most radiosensitive? A. Mature cartilage and connective tissue. B. Bone, marrow, and intestinal crypt cells. C. Neurons and skeletal muscle. D. Hepatocytes and renal tubular cells. Answer: B. Bone marrow and intestinal crypt cells. Explanation: the law of Bergoni and Tribando states that cells that divide rapidly and have high metabolic activity are most radiosensitive. Bone marrow and intestinal crypt cells are highly proliferative, making them highly sensitive to radiation. Option A is incorrect because cartilage and connective tissue are radioresistant. Option C is incorrect because neurons and skeletal muscle cells are non-dividing and thus highly radioresistant. Option D is incorrect because hepatocytes and renal tubular cells have low mitotic rates, making them moderately radiosensitive. Question 10. Radiation safety and ALARA principles. A radiologic technologist is working in an interventional fluoroscopy suite where high radiation doses are frequently used. To follow ALARA as low as reasonably achievable principles, the technologist should A. stand as close to the patient as possible to minimize scatter radiation exposure, B. minimize time, increase distance, and use appropriate shielding, C. rely solely personal dosimeters to ensure safety from radiation exposure, D. Avoid the use of lead aprons as they increase patient dose due to secondary scatter. Answer B. Minimize time, increase distance, and use appropriate shielding. Explanation: ALARA principles focus on time, distance, and shielding to reduce radiation exposure. Option A is incorrect because standing closer increases exposure due to the inverse square law. Option C is incorrect because dosimeters only monitor exposure, they do not protect against it. Option D is incorrect because lead aprons effectively shield against scatter radiation. Question 11. Radiation exposure in pregnancy. A pregnant radiologic technologist is concerned about potential fetal exposure to radiation. According to SRP guidelines, the recommended dose limit to the fetus for the entire pregnancy is 850 mSv, B 10 mSv, C 5 mSv, D 0.5 mSv. Answer C 5 mSv. Explanation: the dose limit for a fetus is 5 mSv for the entire pregnancy, with no more than 0.5 mSv per month. This guideline minimizes the risk of teratogenic effects and fetal malformations. Question 12. Stereotactic radiosurgery (SRS) versus conventional radiotherapy. A patient with a brain metastases is considering stereotactic radiosurgery (SRS) instead of conventional fractionated radiotherapy. Which of the following is the most significant advantage of SRS? A. It delivers a single high dose with submillimeter precision, minimizing damage to healthy tissue. B. It is primarily used for large tumors that require multiple fractions. C. It is less effective than conventional therapy due to the lack of fractionation. D. It is not suitable for intracranial tumors due to high-dose deposition. Answer A. It delivers a single high dose with submillimeter precision, minimizing damage to healthy tissue. Explanation: SRS delivers a high dose in a single or few fractions using advanced imaging and robotic guidance. Option B is incorrect because SRS is used for small, well-defined tumors. Option C is incorrect because SRS has a high tumor control rate despite lacking fractionation. Option D is incorrect because SRS is specifically designed for intracranial tumors. Question 13. Radiation dose calculation in a heterogeneous medium. A patient undergoing external beam radiotherapy EBOT for lung cancer presents with a tumor located behind a lung tissue interface. The treatment planning system needs to correct for tissue heterogeneity because lung tissue has a lower density than muscle and bone. Which of the following corrections is most appropriate for dose calculation in lung tissue? A. Use the TAR tissue-air ratio method, which assumes a homogeneous medium for all calculations. B. Apply Monte Carlo simulations for accurate dose prediction in heterogeneous regions. C. Assume that lung tissue has the same attenuation properties as soft tissue since both are composed of similar elements. D. Use CT-based density correction, but ignore electron scatter effects as they are negligible in lung tissues. Answer B. Apply Monte Carlo simulations for accurate dose prediction in heterogeneous regions. Explanation: Monte Carlo simulations provide the most accurate dose calculations in heterogeneous media because they model photon interactions at a microscopic level. Option A is incorrect because the TAR method assumes a homogeneous medium, which is not valid in lung regions. Option C is incorrect because lung tissue has a much lower density than soft tissue, requiring corrections. Option D is incorrect because electron scatter effects are significant in lung regions due to their lower density. Question 14. Radiation protection in fluoroscopy. A cardiologist is performing an interventional fluoroscopic procedure that requires prolonged radiation exposure. The radiation protection officer recommends methods to reduce the physician's exposure. Which of the following techniques is the most effective in reducing radiation dose to the cardiologist? A. Increasing the distance between the physician and the radiation source following the inverse square law. B. Standing directly in the beam path to ensure minimal scatter radiation exposure. C. Lowering the fluoroscopy KVP setting to reduce scatter radiation. D. Relying solely on lead aprons without additional protective barriers. Answer A. Increasing the distance between the physician and the radiation source following the inverse square law. Explanation: Inverse square law. Doubling the distance from the source reduces exposure by a factor of 4. Option B is incorrect because standing in the beam path increases exposure. Option C is incorrect because lowering KVP increases patient dose due to reduced penetration, which requires higher mass. Option D is incorrect because lead aprons protect only against scattered radiation, not the primary beam. Question 15. Radiobiological effects of linear energy transfer. Two radiation oncologists are discussing the biological effectiveness of different radiation types. They compare low-let radiation, X-rays, gamma rays with high-let radiation, alpha particles, neutrons in terms of their impact on cell survival. Which of the following statements is true regarding LET and biological damage? A. High-let radiation causes more clustered DNA damage, leading to lower cell repair probability. B. Low-let radiation is more effective than high-let radiation for killing tumor cells. C. Alpha particles and neutrons, high-let, produce more single-strand DNA breaks than X-rays. D. High-let radiation has a low relative biological effectiveness, or B, than low-let radiation. Answer: A. High-let radiation causes more clustered DNA damage, leading to lower cell repair probability. Explanation: high-let radiation causes dense ionization along its track, resulting in complex DNA damage that is harder to repair. Option B is incorrect because high-let radiation has greater biological effectiveness than low-let radiation. Option C is incorrect because high-let radiation causes more double-strand breaks, not single-strand breaks. Option D is incorrect because high-let radiation has a higher RB. Question 16. Shielding design for a LINAC facility. A medical physicist is designing a radiation shielding plan for a linear accelerator LINAC room operating at 6 MV and 15 MV photon energies. The goal is to protect staff and patients outside the treatment area. Which of the following is most important when determining the required thickness of lead or concrete shielding? A. The attenuation coefficient of lead at 6 MV, since higher energy photons do not require additional shielding. B. The workload W, use factor U, and occupancy factor T to calculate weekly dose limits. C. The thickness required to completely block all scattered photons to avoid any exposure. D. The patient's treatment fractionation schedule, as it determines individual exposure times. Answer: B. The workload W, use factor U, and occupancy factor T to calculate weekly dose limits. Explanation: shielding calculations use workload W, total radiation output per week, use factor U, fraction of time the beam is aimed at a particular wall, occupancy factor T, how frequently an area outside the room is occupied. Option A is incorrect because higher energy beams e.g. 15 MV require additional shielding for neutron production. Option C is incorrect because complete blocking is impractical and dose limits are set based on ALARA principles. Option D is incorrect because fractionation affects patient dose but not shielding calculations. Question 17. Dose constraints in radiation therapy. A radiation oncologist is treating a patient with head and neck cancer using intensity modulated radiation therapy. The oncologist wants to minimize dose to the parotid glands while delivering a high dose to the tumor. What is the recommended dose constraint for the parotid glands to reduce xerostomia risk? A. Mean dose 26 GI. B. Maximum dose 60 GI. C. Mean dose 45 GI. D. There is no dose constraint for the parotid glands. Answer: A. Mean dose 26 GI. Explanation: mean dose 26 GI significantly reduces the risk of radiation-induced xerostomia. Option B is incorrect because 60 GI is too high for preserving parotid function. Option C is incorrect because 45 GI is still too high for optimal function preservation. Option D is incorrect because parotid dose constraints are crucial in head and neck radiotherapy. Question 18. Radiation dose in MRI-LINAC hybrid systems. MRI-LINAC hybrid system is used for real-time adaptive radiotherapy. Unlike conventional LINACs, this system uses strong magnetic fields during radiation delivery. How does the magnetic field affect dose distribution? A. It alters electron trajectories, leading to dose perturbations in tissue-air interfaces. B. It increases photon beam attenuation, reducing target dose. C. It eliminates all radiation scatter, improving dose conformity. D. It has no impact on radiation dose delivery. Answer: A. It alters electron trajectories, leading to dose perturbations in tissue-air interfaces. Explanation: magnetic fields deflect secondary electrons, causing dose perturbations at air-tissue interfaces, e.g. lung boundaries. Option B is incorrect because photons are unaffected by magnetic fields. Option C is incorrect because scatter radiation still occurs. Option D is incorrect because MRI-LINAC systems alter dose deposition. Question 19. Dose distribution in brachytherapy. A radiation oncologist is planning a high-dose rate HDR brachytherapy treatment for a patient with cervical cancer using an O192 source. The oncologist wants to optimize dose distribution while minimizing dose to the bladder and rectum. Which of the following best describes how dose distribution is affected in HDR brachytherapy? A. Inverse square law dominates, meaning dose falls off rapidly with distance from the source. B. Scattering from adjacent tissues significantly alters the dose, making it unpredictable. C. The dose is uniform within a 10 cm radius of the source. D. The dose to the organs at risk ORS is primarily determined by photon energy rather than distance. Answer: A. Inverse square law dominates, meaning dose falls off rapidly with distance from the source. Explanation: HDR brachytherapy sources e.g. O192 deliver dose based on the inverse square law, meaning small changes in distance cause large dose variations. Option B is incorrect because scatter has minimal impact compared to primary dose deposition. Option C is incorrect because dose falls rapidly beyond a few millimeters, not uniformly over 10 centimeters. Option D is incorrect because distance plays a greater role in dose fall than photon energy. Question 20. Radiation-induced secondary malignancies. A 40-year-old female patient receives adjuvant radiotherapy for breast cancer with a prescribed dose of 50 Gi to the tumor bed. The patient is concerned about the long-term risks of radiation-induced secondary cancers. Which of the following factors most significantly influences her risk of developing a secondary malignancy? A. Total radiation dose and volume of normal tissue irradiated. B. Patient's genetic predisposition alone. C. Type of radiation, photons versus protons has no effect on secondary cancer risk. D. Radiation dose rate is not significant factor. Answer: A. Total radiation dose and volume of normal tissue irradiated. Explanation: secondary cancer risk is dose dependent, with higher doses and larger irradiated volumes increasing the risk. Option B is incorrect because while genetic predisposition area mutations can contribute, radiation dose plays a larger role. Option C is incorrect because protons have a low secondary cancer risk than photons due to reduced out-of-field dose. Option D is incorrect because dose rate affects biological repair mechanisms influencing cancer risk. Question 21. Lethen or BE in proton therapy. A medical physicist is analyzing the relative biological effectiveness or BE of protons in a pencil beam scanning system. The physicist notes that OBE varies along the Bragg peak. Which of the following is true regarding Lethen or BE in proton therapy? A. RBE increases near the distal end of the Bragg peak due to higher Let, but RBE remains constant throughout the Bragg peak region. C. Proton Let is highest at the entrance dose region. D. Proton therapy has the same biological effectiveness as X-rays at all depths. Answer: A. RBE increases near the distal end of the Bragg peak due to higher Let. Explanation: RBE increases near the Bragg peak's distal edge due to higher Let, leading to greater biological damage. Option B is incorrect because RBE varies and is not constant. Option C is incorrect because Let is lowest in the entrance region and highest at the Bragg peak. Option D is incorrect because protons have higher RBE on 0.1 compared to X-rays 1.0. Question 22. Radiation exposure in space. Astronauts on a deep space mission to Mars will be exposed to galactic cosmic radiation, GCR, and solar particle events, SPECE. Which of the following best describes the radiation risk astronauts will face? A. High-Let heavy ions in GER cause greater DNA damage than low-Let radiation. B. Only low-Let radiation is present in space, making shielding unnecessary. C. Radiation exposure in space is lower than on Earth due to the absence of atmospheric scattering. D. The Earth's magnetic field increases astronaut exposure in space. Answer: A. High-Let heavy ions in GCR cause greater DNA damage than low-Let radiation. Explanation: high-Let radiation, e.g. heavy ions from cosmic rays, causes complex DNA damage, increasing cancer risk. Option B is incorrect because space radiation includes both high-Let and low-Let components. Option C is incorrect because space lacks atmospheric protection, increasing exposure. Option D is incorrect because Earth's magnetic field reduces radiation exposure, not increases it. Question 23. Radiopharmaceutical dosimetry, a nuclear medicine physician administers I-131 therapy to a patient with thyroid cancer. The goal is to maximize dose to the tumor while minimizing dose to normal tissues. Which of the following factors most significantly influences absorbed dose in target tissues? A. Half-life and biological clearance rate of the radiopharmaceutical. B. Photon energy alone determines the therapeutic dose. C. The patient's age does not affect radiopharmaceutical distribution. D. Only physical decay is relevant in dose calculation. Answer: A. Half-life and biological clearance rate of the radiopharmaceutical. Explanation: absorbed dose depends on both physical half-life and biological clearance, affecting how long the isotope remains in the body. Option B is incorrect because dose is influenced by both biological uptake and decay. Option C is incorrect because younger patients may have different metabolic rates affecting biodistribution. Option D is incorrect because biological clearance is just as important as physical decay. Question 24. Neutron contamination in high-energy LINACs. A medical physicist is evaluating neutron production in a 20 MV LINAC. Which of the following statements is correct regarding neutron contamination? A. Neutrons are produced at energies above 10 MV and contribute to patient dose. B. Neutron production only occurs in proton therapy, not LINACs. C. Photoneutrons do not interact with the patient's tissues. D. Using lower energy LINAC, 15 MV, increases neutron contamination. Answer: A. Neutrons are produced at energies above 10 MV and contribute to patient dose. Explanation: neutrons are produced via photonuclear reactions when beam energy exceeds 10 MV, adding an unwanted dose component. Option B is incorrect because neutron production occurs in LINACs at high energies. Option C is incorrect because photoneutrons interact with tissues, increasing dose uncertainty. Option D is incorrect because using lower energy beams, 10 MV, reduces neutron contamination. Question 25. MRI artifacts in radiation therapy. An oncologist is using MRI-guided radiotherapy for a prostate cancer patient. However, MRI images show metal-induced distortion artifacts near a hip implant. What is the most appropriate method to reduce the image distortion? A. Use a lower magnetic field strength. B. G 1.5 it instead of 3. B. Increase the gradient field strength to eliminate artifacts. C. Ignore the distortion as it does not impact treatment planning. D. Use CT instead, as MRI is not necessary for treatment planning. Answer: A. Use a lower magnetic field strength. E. G 1.5 it instead of 3. Explanation: low magnetic fields reduce metal artifacts, improving image quality. Option B is incorrect because higher gradients do not remove metal artifacts. Option C is incorrect because ignoring distortion affects accuracy. Option D is incorrect because MRI provides superior soft tissue contrast. Question 26. Fractionation in radiotherapy. A 65-year-old patient with head and neck cancer is scheduled for definitive radiotherapy using a fractionated dose of 70 Gi in 35 fractions over 7 weeks. Which of the following best describes the biological rationale for fractionation in this patient's treatment? A. Fractionation allows for better repair of normal tissue while maintaining tumor control. B. Larger single doses of radiation provide better outcomes than fractionated treatment. C. Fractionation increases tumor repopulation, reducing treatment effectiveness. D. Prolonging the total treatment time has no effect on tumor response. Answer: A. Fractionation allows for better repair of normal tissue while maintaining tumor control. Explanation: fractionation maximizes tumor kill while sparing normal tissues by allowing repair of subalthal damage. Option B is incorrect because single large doses increase normal tissue toxicity. Option C is incorrect because fractionation limits tumor repopulation, not increases it. Option D is incorrect because prolonging treatment time may allow repopulation, reducing effectiveness. Question 27. Oxygen enhancement ratio OA in hypoxic tumors. A radiation oncologist is treating a patient with a hypoxic tumor that is poorly oxygenated due to limited blood supply. Which of the following statements about oxygen enhancement in radiation therapy is correct? A. Hypoxic tumors are more resistant to radiation than well-oxygenated tumors. B. Oxygen has no effect on radiation-induced DNA damage. C. The oxygen enhancement ratio OA is higher for high-LET radiation compared to low-LET radiation. D. Hypoxic tumors respond equally well to conventional fractionation and hypofractionation. Answer A. Hypoxic tumors are more resistant to radiation than well-oxygenated tumors. Explanation. Oxygen enhances radiation-induced DNA damage, making hypoxic tumors more resistant. Higher survival rates. Option B is incorrect because oxygen increases DNA damage via free radical formation. Option C is incorrect because high-level radiation has a lower OA, meaning it is less affected by oxygen levels. Option D is incorrect because hypoxic tumors respond differently to various fractionation schedules. Question 28. Shielding design for radiation therapy rooms. A hospital is constructing a new radiation therapy department with a 15 MV linear accelerator. The medical physicist is tasked with designing appropriate shielding to protect staff and the public. Which of the following factors must be considered when determining the thickness of shielding required? A. Beam energy, workload, occupancy factor, and use factor. B. Only the type of radiation, photons versus electrons. C. The presence of EMAs is irrelevant in shielding calculations. D. Only the number of patients treated per day affects shielding requirements. Answer A. Beam energy, workload, occupancy factor, and use factor. Explanation. Shielding calculations depend on multiple factors including beam energy, workload, use factor, beam direction, and occupancy who is nearby. Option B is incorrect because both beam energy and shielding material affect dose attenuation. Option C is incorrect because EMAs reduces neutron exposure affecting shielding design. Option D is incorrect because shielding must account for both daily and long-term exposure levels. Question 29. Radiation-induced cataract formation. A 50-year-old interventional radiologist has been exposed to chronic low doses of radiation over several years due to fluoroscopy-guided procedures. The physician is concerned about the risk of developing radiation-induced cataracts. Which of the following statements about radiation-induced cataracts is correct? A. Cataracts have a lower threshold dose with fractionated exposure compared to acute exposure. B. Cataract formation is a stochastic effect with no clear dose threshold. C. Radiation-induced cataracts are primarily associated with high-energy neutron exposure. D. Lead glasses provide no significant reduction in cataract risk. Answer A. Cataracts have a lower threshold dose with fractionated exposure compared to acute exposure. Explanation. Cataracts follow a deterministic effect with a threshold dose, and fractionated exposure has a lower threshold 0.5 GI than acute exposure 2 GI. Option B is incorrect because cataracts are deterministic, not stochastic. Option C is incorrect because photons and beta particles, not just neutrons, can cause cataracts. Option D is incorrect because lead glasses reduce lens dose, lowering cataract risk. Question 30. Image-guided radiation therapy in motion management. A patient undergoing stereotactic body radiation therapy (SRT) for lung cancer exhibits tumor motion due to breathing. The treatment team considers image-guided radiation therapy to manage motion. Which of the following techniques is best suited for motion management in lung cancer? A. Forward CT and respiratory gating. B. Single static AV imaging before treatment. C. MRI-guided therapy is not useful for lung tumors. D. CT-guided therapy is not affected by tumor motion. Answer A. Forward CT and respiratory gating. Explanation. Forward CT captures motion throughout the breathing cycle, and respiratory gating synchronizes treatment with breathing. Option B is incorrect because single static images do not capture motion. Option C is incorrect because MRI-guided therapy can track lung tumors in real time. Option D is incorrect because tumor motion affects all imaging modalities.